Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Is Dr. Tiago Caramelo. Dr. Tiago, are you there?
Yes, I'm here.
All right. Dr. Tiago Caramelo received his dental degree in 2013 from the University of Lisbon from the Faculty of Dental Medicine. 1 year later, he started working as a dentist at a prosthodontic department in MALO Clinic, Lisbon. You're going to tell us about MALO Clinic. From 2004 to 2016, he was a clinical assistant professor of oral surgery, a clinical assistant of oral surgery at the Department of Oral Surgery Department at the University of Lisbon, the Faculty of Dental Medicine. In 2016, he became the coordinator of the MALO Clinic Verona in Italy and the MALO Clinic in the United Kingdom. Since the start of his career, he has been attending several post-graduations worldwide with recognized dentists such as Pascal, David, and Maxim. I mean, these are trained hands, and dentistry, before you know it, is something you have to learn from someone, and he has been blessed to be able to learn from master teachers. His clinical practice is focused on fixed prosthodontics and full arch rehabilitation. Dr. Caramelo, it's a pleasure to have you in Dental Webinar Series.
It's a pleasure for me too, to be here. Let's try to share my screen. Okay. I think you can see, right?
Yes, very clear. Good.
Okay. So, hi everyone. Like Uvoh said, my name is Tiago Caramelo, and I've been working in MALO Clinic, Lisbon, as a prosthodontist since 2014. I graduated in the same city in 2013, and I have been working also abroad. It means in Verona and in Windsor, UK, where I was part of the team doing full arch cases as a prosthodontist, and the team has a surgeon, has a technician, and has me as a prosthodontist. I want to thank Uvoh before start speaking for the invitation you made me, and I hope you enjoy the next 40 minutes about this important topic of dentistry, that is full arch rehabilitation. When we talk about an All-On-4, we are talking about a full arch rehabilitation that changes completely the life of this patient. It doesn't change just the teeth, just the smile, but changes much more than that: the chew capacity, the phonetics, the life of a person. And almost all people that want to do this type of treatment are searching for an improvement of their self-esteem. And with our All-On-4, we can make this patient's life easier. We can finish with 2 definitive bridges, beautiful, as you are seeing, these ones. This is just an example of what All-On-4 can do for our patients. Of course, that the All-On-4 didn't start 27 years ago, as I show you in these pictures. This is a result of several research that we have been releasing throughout the years, and always with the aim of living longer, of avoiding complications, etc., etc. We have been rethinking our oral rehabilitation. Of course, as the time goes by, the full arch rehabilitation has been improved. We start with these fixtures that you are seeing a lot of years ago, and then the implants just came in, where we just started to do full arch cases with 8 implants, 10 implants, telling the patients to wait 6 months for the delivering of the teeth. And then with the development of the All-On-4 and the immediate loading concept, we have been changing the way of thinking in full arch rehabilitation. And even when we don't have bone at all, we just can go for the zygomas and solve the case. Basically, the concept of full heart rehabilitation has been changed throughout the years, and the comfort that we can give to our patients nowadays, it's not comparable of what we were used to a few years ago. But basically, what is an All-On-4? All-On-4 is a technique where we put 4 implants to do a full heart reconstruction. The angulation of the posterior implants is at most 45 degrees. Then it's compensated with 30 degrees multi-unit abutments. The implant's anchorage can be in jaw or not. Sometimes we do bicortical in order to achieve high stability of the implants, high torque, and then we can deliver fixed teeth because of that. We use cantilever if needed. Of course, we prefer not to use it, and we do everything by tilting the posterior implants not to have cantilevers, but if it's necessary, we do it. The immediate function, of course, it's the main purpose for this technique, and we do bone reduction if we need to do it. And why All-On-4 and not other technique? First, All-On-4 avoids bone graft, and it has high success rates, as I will show you in some studies that we published. The high hygiene maintenance capability in comparison with other protocols with 8 implants, 10 implants, 6 implants, it's something that we have to say. And once again, the main purpose, this technique allows the patient to immediately have teeth in the same day of the surgery. The protocol includes these 3 steps. Of course, the first step that for me it's the most important one, it's the diagnosis and treatment plan. It includes X-rays, CT scans, smile line, lip support, DVO, pictures and videos, preliminary impressions, something that is similar to the other techniques. Let's start speaking about diagnosis. When we have full bone volume, we can decide to do 6 implants, as you will see in this picture, 8 implants, parallel implants. So we can do All-On-4 as well. When we start to having just bone available until first molar or until second premolar or even until first premolar, we have to start thinking about other techniques. We also can do bone grafts in posterior region and put straight implants, but sometimes to do this, we have to tell the patients to wait to deliver fixed teeth, or we just can do an All-On-4 in the anterior region and then do bilateral sinus graft and put more implants in posterior. We can do also overdentures, for example, removables. There are a lot of procedures that we can do. Of course, here I'm talking about the All-On-4. That is also an available option for this type of situations. When we have bone available until lateral incisor, we can go for an All-On-4 hybrid. It's what we call when we do a mixture between zygoma implants and axial implants or conventional implants. For us, this is the All-On-4 hybrid. You can also do bone graft once again in posterior. And when we have no bone at all, we can go for the zygoma to do All-On-4 double zygomas. It means 2 zygomas in 2 zygoma implants in each zygoma. In the mandible, once again, if we have full bone volume, we can go, for example, for 6 implants, but actually in mandible, we always use the All-On-4 concept that is very successful in this type of job. The bone reduction, it's a controversial issue that has been discussed throughout the years. We do it, and we do it depending on these 3 aspects. First, the prosthetic space. It means we have to have space for the final bridge. Then smile line. We want to avoid transitions between natural gum and the final bridge. And sometimes, as you will see next, we reduce bone in order to hide that transition. And lip support, you will see, we don't want when the patient smiles to the lip get stuck, We don't want like a platform where there is food impactation, and sometimes to avoid this type of situations, we have to reduce bone and we have to put the bone a little bit upper so we can avoid this type of problems. For example, in this situation, when we are doing a full arch rehabilitation here, we like to do bone reduction. Let's take a look at this gum, a lot of gum when the patient smiles. So we have two types of smile lines. Either we have a high smile line. It means when the patient smiles, we will see the gum, as you will see on your left. And then when the smile line is low, the patient, even when they smile as much as possible, they don't show any gum. For example, here, the patient smiles, the lip gets up, and we'll see some gum. In this type of situations, either we do a metalloceramic prosthesis without artificial gum and without bone reduction, but in this type of situations, it's difficult to achieve a good long-term aesthetic. And why? Because then after a few years, we have some recessions, we have to do some soft tissue grafts, and that's why long-term is not so predictable as reducing the bone and avoid the transition. And of course, it's a very demanding surgical technique because it requires us to put the implants in the right positions in the middle of the teeth. And sometimes it's difficult to do a situation like that. This is a result of a bridge without artificial gum. It means with just teeth. Then, with the All-On-4 protocol, we reduce the bone, and then when the lip gets up, we don't see any transitions, as you can see in this picture. So this is a comparison. When we do bone remodeling, it means when we do bone reduction on the right one, and where we don't do any bone reduction on the left one. And then you can see the difference. And it's more predictable long-term when we do this type of cases. When the smile line is low, everything is easier because actually we don't have to do bone reduction because the patient doesn't show. So we can proceed with our bridge without doing bone reduction. About the lip support, it's other aspect that make us do bone reduction, as I told you. The loss of natural dentition and the bone resorption will result in lack of lip support. But if we have just a small lack of lip support, we can try not to reduce, do our bridge. But if you have, and why? Because the angulation of the false gingiva between the natural gingiva and the false gingiva is less than 45 degrees. But when we have a severe lack of lip support, look at this angulation. It's much more than 45 degrees. What makes it uncomfortable for the patient? What makes difficulty on oral hygiene procedures, and even when they smile, as I told you before, the lip gets stuck, and we don't want to do this type of these situations to happen. So here we have two options. We can do like an overdenture with flanges, or we can just do some bone reduction and then putting the implants and then doing a bridge with an angulation less than 45 degrees. Here, we avoid food impactation and we avoid the lip to get stuck. So this is another parameter that makes us do bone reduction before putting the implants. This is part of diagnosis and treatment plan, what I just said to you, to help us preparing the day of the surgery and the provisional bridge that we are going to deliver in the day of the surgery in the right way. So let's advance for the day of the surgery. I have here a video, just of course not a complete video, but a video of 10 minutes explaining the procedure since the beginning until the end of the day. I will just explain to you. I will stop a few times so I can explain better. How do we do this? We start with an incision over the crest, slightly palatal, and two release incisions in the molars region. Then we'll start to open the flap, as you are seeing. We like to do this suture in palatal area so we can see better the bone. We take out all the soft tissue around the bone. We start to do the bone reduction or the bone remodeling. Sometimes we just have to do some bone remodeling to put the implants. Here, this is the first drill that we do. We try to do a drill in the midline, perpendicular to the B pupillary line. It means that it will be completely perpendicular to the B pupillary line, and it will help us to put, for example, the anterior implants completely parallel to this pin guide that we will put, as you are seeing. So we start drilling, starting with the 12th implant. This is the implant we use. This is the Nobel Speedy Groovy. That is a fully threaded implant from the tip to the top and help us to reach high stability. We like to do immediate loading when we have plus than 30 newtons. And we always do the rehabilitation at multi-unit level, as you are seeing. Here we put a 2 mm straight abutment in the anterior implant. Then we go for the posterior. If you are a beginner doing this, we can like doing this window in the anterior wall of the maxilla to check where the sinus is, so we can tilt the implant as much as possible without touching the sinus. That's what we are doing here. Here we know where the sinus is here, so we can tilt as much as possible. Sometimes, in order to achieve, as I told you, high stability, we do bicortical anchorage in the facial, in the fossa nasal, nasal fossa. Sorry. Drilling. Once again, Nobel Speedy Groovy, external connection, threads from the tip to the top. This is the bone mill. It avoids us to have bone interference, help us removing the bone around the platform so we can engage correctly the 30 degrees multi-unit abutments. You have 4 millimeters, 30 degrees, or 5 millimeters, 30 degrees. You choose according to the height of the gum and to where the implant is. It depends. Then we are going for the second quadrant. Implant on 22. Sometimes we start with the posterior implants and then we go for the anterior. In this case, actually, we started with the anterior ones. Let's go for the multi-unit straight abutment. We torqued it. Then we are going for the posterior. We use this All-On-4 guide to know exactly the angulation that we are doing with the drill. Because if we did this first drilling perpendicular to the bipupillary line, we are putting this guide parallel to the bipupillary line. So we can know exactly that these lines you are seeing here are parallel. So we know that we cannot angulate, or we should not doing it more than 45 degrees, and this guide helps us to do the right angulation. Once again, Nobel Speedy Groovy, external connection. We can leave this type of decency, as you see. It's no problem. We have some studies that show that 10 years follow-up not brings any problem for the implants. Then we start to take out the sutures. Sometimes we have to, because we did some bone reduction, we have to take out some of the gum so you can suture correctly. And then we are going for the impression to prepare the bridge. These are 4 impression cuppings that we screwed at multi-unit level, and then we connect these impression cuppings with this pattern resin. You can use acrylic, you can use pattern resin, it's up to you. You just have to have the impression cuppings rigidly connected. We like to do it crossed. It means if we start with the implant 12, then we are going to the 26, and then we are going with the 15, and we finished with the 22. At this point, we like to do impression just with putty material. We use these trays with light cured acrylic that we do in our lab. As I told you, at this point, we just use putty material. Why? Because in past, we already had some failures of implants that just came out with light material around. So since then, in order to avoid that the light material goes under the soft tissue, we decide just to do impressions with putty material. At this phase, it's much more than enough, and we feel comfortable with that. So some putty material in the mouth, some putty material in the tray, and we wait 5 minutes, we start unscrewing, and it's done, our impression. Then at this point, these are the healing caps that we put to avoid the soft tissue to go over the multi-unit abutment. Then, as I told you, at this point, we have 2 ways, we have 2 ways of doing the bridge. Either we have a bridge prepared from the beginning, as you are seeing here. Either we have a bridge prepared from the beginning that we just have to adapt into the implants, or we just prepare a bridge completely from the beginning. It means doing impressions, doing bite block registration, doing trains and processing in the same day. Of course, to do this, you have to have your own lab. We have a lab at the clinic. Sometimes we have to do it, especially in cases where the patients, when the patient have mobility grade 3, for example, where we cannot do preliminary impressions before the surgery. Thank God it's not usually, but sometimes it happens. In almost all cases, we do, as I'm showing you here, we have a bridge prepared from the beginning. We screw 2 cylinders in the anterior region, and then we do the pickup of these cylinders with acrylic. We open 2 holes in the bridge. We check everything, if it's correct, the midline, the aesthetics, the occlusion. And then after guaranteeing that everything is correct, we put some cotton balls inside the cylinders, to avoid that the material goes inside the cylinders. And then some acrylic around the cylinders. We put the bridge and we do the pickup of those 2 anterior cylinders. We just do the 2 anteriors, and why? Because the lab will conclude the work by picking up the 2 posterior ones. If we have any doubt of the articulation, we can do a bite registration so the lab can re-articulate if necessary. Then we have our bridge with the 2 cylinders picked up. Here you see. And then the lab delivers us this final bridge with then the posterior cylinders already picked up. Usually in the provisional, we just put 10 teeth, not 12 teeth, because we don't want to overload the posterior implants. But in this patient, because he didn't have molars in the lower jaw, there was no problem. And we delivered the bridge with 12 teeth. Then we check the occlusion. Once again, in the provisional, we prefer to have occlusion from canine to canine, not to overload the posterior implants. Then we fill the holes with cavite material. We polish everything. And this is our All-On-4. Everything in the same day, extracting teeth, putting implants, and delivering this fixed provisional bridge. Okay, but why do we tilt implants? Tilting was in past a controversial issue. Everybody knows this. Nowadays, we have so many articles published that are pro-tilting. I brought 3 of them. This one from Krekmanov in 2000. We know that by tilting, the implant length is increased for sure, as well, and the implant follows as well the bone, dense bone structure, enhancing the primary stability of the implant. This study shows 5 years, 206 implants in a 2-stage procedure. The cumulative success rate was 100% in mandible, in both types of implants, and in maxilla was 95% in tilted implants and 90% in the axial or conventional implants. The conclusions that we can take from this study is implant tilting does not induce any biological disadvantage. In terms of biomechanics, the position of coronal end of implant is more important than whether implant is tilted or not. This was the first study. The second one is from Aparicio with 101 implants, a 2-stage procedure also. In 7 years, it shows success rates 95% tilted with 1.21 millimeters of marginal bone loss versus 91.3% in axial implants and 0.92 millimeters of marginal bone loss. And then our study, published by us in 2013 with great results also, a 3-year study, all implants with immediate function, 176 implants show similar cumulative survival rates and marginal bone loss equal into the same implants in mandible. In terms of biomechanics, we know by reading this study that tilting the implant does not increase bone stress. Look at this. Implant tilted versus implant axial. With the same cantilever, the bone stress is the same. Once again, tilted implant versus axial implant with a cantilever, bone stress is the same. 2 different implants, both tilted with different sizes, the bone stress is the same. So, distal tilting of implants in splinted fixed restorations does not increase bone stress. Stressing bone is lower when we use tilting implants instead of cantilevers. As I told you from the beginning, we try to avoid cantilevers as possible. So every time we have bone, we angulate the implant as much as possible to avoid cantilevers. Sometimes we cannot do it, but every time we can, we do it. This study shows that as much as we reduce the cantilever, we are reducing also the bone stress on the metal frameworks and on the implants. Look at this. If you reduce a little bit, 12%, then 47%. If we have no cantilevers, we reduce the bone stress in 73.5%. The same thing in metal frameworks. So, tilted distal implants rigidly splinted with a fixed prosthesis decrease stress in the peri-implant bone and frameworks. These are the advantages of tilting implants in terms of biomechanics. So, after 6 months of healing period, we proceed with the final bridge. The final bridge, the best solutions that we can provide to our patients are these 2 bridges. The MALO ceramic bridge, as we called it, on your right, it's an infrastructure, a titanium infrastructure where we cement 12 ceramic crowns one by one, as you will see next. And the MALO acrylic bridge, it's a titanium with acrylic bridge, conventional titanium acrylic bridge. Here you can see an intraoral picture of both bridges together. Let's start speaking about the MALO ceramic bridge. As I told you, it's a fixed screwed bridge over implants with titanium's infrastructure novel procedure, where we cement 12 individual ceramic crowns and then where we put artificial gingiva. These 12 ceramic crowns, you can use the material you want. A few years ago, we used zirconia ceramic crowns, but then we had some shippings like everybody else, so we stopped doing those type of ceramic crowns, and nowadays we are doing monolithic crowns. Emax press crowns is the material that we have been using, but it's, as I told you, it's up to you. If we have a Bruxelman patient, we can cement 12 zirconia monolithic crowns, for example. I think for me, this is the big advantage of this bridge. And imagining after 10 years, you have a fracture of one crown. You just have to replace that crown. The bridge doesn't have to go to the oven because you just have to do that ceramic crown that is cemented to the infrastructure. For me, this is the big advantage of this bridge. The advantage is perfect adaptation, low weight and density, great resistance. You can choose, as I told you, different types of ceramic cemented. It's easy to repair, because as I told you, you can change just one crown, just two crowns. You don't have to put all the bridge in the oven. It's easy to reline. And why? Because we use acrylic in the gum part, in the gingiva part. So if we have some gap after a few years, you can just reline that part by adding some acrylic. It's a very aesthetic bridge. The disadvantages of this bridge: the extended time that requires, and of course it's expensive for all the time that we lose doing this. To do this type of bridge, we have to have something to duplicate. Either we have a provisional that is good, that we can duplicate to the final, either we do a second provisional bridge completely aesthetic as we want and as the patient likes, and then we duplicate that second provisional bridge, or we just can duplicate the try-in that we did and the patient likes that try-in. So to duplicate, we use this material from an accident that we call Fast Protect. It has two sides. In one side, we put what we want to duplicate. In the other side, we just put a matrix, we close it. And then we have the matrix, the negative of what we duplicated on your left side. On the right side, we can unscrew the train or the bridge. We can put 4 cylinders. We can close it once again and inject some acrylic inside. And we have a duplication of what we just duplicated. This can be our acrylic guide to prepare the final bridge. Then we prepare tooth one by one, drilling one by one, preparing. Our acrylic guide is prepared. We do the CAD, it means we do the computer-aided design. We send to Nobel. Nobel does the CAM, it means mills this infrastructure, send back to us this titanium infrastructure, where, because we had a matrix of the duplication, we just can close it again with wax, and then we have our titanium infrastructure with 12 wax crowns that then, with the wax loss process, we can do these Emax press ceramic crowns. As I told you, we have been using in the last years this type of material, but you can choose other material if you want. We like to cement these 12 ceramic crowns with this multi-link hybrid abutment. It has different types, different opacities. And this is our ceramic bridge ready to try. The MALO acrylic bridge, as I told you, it's a fixed screwed bridge over implants with titanium infrastructure inside, and where we put 12 acrylic teeth and the artificial gingiva. The big advantage for me of this bridge is you can replace after a few years of using. Of course, you will have wear, you will have pigmentation. These are the disadvantages of this bridge. But for me, the big advantage of this bridge is in one day you can change all the teeth of the bridge. And I've been changing some teeth of MALO acrylic bridges with 8 years of using 10 years, 12 years. In one day, the patient just came in. We take out all the acrylic. We keep the same infrastructure that is actually what is expensive. We do another train of acrylic around, and in the same day, it's like if they have, if they had a new bridge in the same day by paying half of a new MALO acrylic bridge. For me, this is the big advantage of using this type of bridge. Once again, we design the titanium bar in our lab, and then we send to Nobel that prepares this titanium infrastructure and send back to us. We use this opaque to cover, to hide the titanium spoiler, and then 12 acrylic teeth around. It's ready to try. We try it, it's okay, we process, we deliver. This is the delivery of the bridges. We like to give to our patients these night guard protections. And this is the delivery of our final bridges. MALO ceramic bridge in the upper jaw with 12 ceramic rounds against a metallo acrylic bridge in the lower jaw. This is the final OPG. Some x-rays, very apical x-rays. And why do we do this? All-on-4 concept was a controversial concept a few years ago, like everybody of you should know. Nowadays, it's not like that. Even ITI just agrees with All-On-4 nowadays. Even Straumann just released the Pro Harchet. It's an imitation of what All-On-4 is. So nowadays, it's different. I think almost everybody accepts it. We have been releasing some literature about that. It's what I want to show you right now. I brought one article for the mandible and one article for the maxilla, both published last year. This one, mandible, a longitudinal study with 10 to 18 years of follow-up, shows success rates in 1,884 implants with 95.9% in 10 years, 93.5% in 13 years, and 91.7% in 18 years. This is in the mandible. About the maxilla, we have another study published last year with 5 to 13 years of follow-up and shows also good success rates. In 5 years, 97.7%. In 10 years, 95.6%. In 13 years, 93.9%, with a total of 4,288 implants. I just want to conclude showing you some of our clinical cases. We start with standard All-On-4s. This bimaxillary standard All-On-4 that finished with these two bridges. This is a 9 years follow-up from a surgery from 2005 with ceramic on top and metallo acrylic in the lower jaw. Second case. Here we can see a high smile line that shows some gum. So we have to reduce some bone in this case. We did it. We deliver our final bridges. And this is the final result. Once again, the X-ray, panoramic X-ray with 6 years follow-up from a surgery from 2008. Third case, bimaxillary standard All-On-4 with the final pictures. And with an X-ray from a surgery from 2009 with 3 years follow-up. A case of an hybrid All-On-4, it means when we are doing hybrid, as I told you, it means that we do a mixture with zygoma implants and conventional implants. As you can see, just looking through this OPG, there is no bone in the posterior region. Either we do bone grafting and tell the patient to wait 4 to 6 months to have teeth, or to put the implants and then 4 to 6 months to deliver teeth, or we can just do this hybrid All-On-4 and deliver teeth in the same day. And this is an OPG with 4 years follow-up from 2016. This is, she started to do acrylic in both jaws, as you see, and then she preferred to change for ceramic in both jaws. That's why you have 2 OPGs here. A second case, once again, some bone reduction in the anterior region, bridges, the OPG of this hybrid All-On-4. Then the third case, final bridges. And once again, the OPG. I have here one double zygoma case for you to see. Some teeth that we had to extract. Double zygoma case in the upper jaw with a 4 years follow-up. Case number 2, once again, double zygoma. Here you can see. Case number 3, once again, 2 bridges, final bridges, and double zygoma in the upper jaw with 6 years and 5 months of follow-up. This is my last case. It's an All-On-4 extreme. We had to proceed with zygomas also. This patient had an oral cancer. She didn't have maxilla. So this is what we call an All-On-4 extreme. You can see the initial pictures, no maxilla, intraoral pictures. Look at this. No maxilla, almost no bone in the mandible. But Dr. MALO took care of that. He could put 4 implants in the lower jaw, double zygoma in the upper jaw, and we were able to give her the smile back. Final rehabilitation with 8 years follow-up. Before and after. Before and after. Okay, just to conclude, I want to tell you that we have a TV show in Portuguese television where we do full arch cases for free in patients that unfortunately do not have money to afford it. And it's an honor for me being part of this team and can rehabilitate patients that otherwise wouldn't be able to do it. This is my email. If you want if you have any doubt, just text me and I will reply as soon as possible. Thank you, everyone. Uvoh.
I have some questions.
Let me just try to see where the questions are. You mentioned easy repair of fractured crowns as an advantage of MCB. It's also easy to repair the bridge in cases of fractures of the titanium infrastructure. Of course, if you fracture the titanium infrastructure, you have no chance. You have to repeat everything again. But I can told you that I already did thousands of cases and I've never had one fracture of titanium infrastructure. Of course, that because of that, you have to have space for the titanium infrastructure. And sometimes you have to do bone reduction because of that. Usually we don't have fractures of the titanium infrastructure. You have fractures of the crowns, of the teeth. And in those cases, it's very easy to repair. If you have a fracture of the infrastructure that, as I told you before, it's not so usual. Actually, I've never had one. In those cases, you have to repeat everything from the beginning. What is the age limit of these procedures due to prolonged time of mouth opening that can easily lead to fatigue? I can tell you that I think 6 months ago, we did a bimaxillary case in a 90-year-old guy. Of course, that we did it under general anesthesia. So it's not a limit age to do this type of procedures. It depends on the patient. It depends on the health conditions of the patients. And sometimes, in order to do this, we have to do under general anesthesia condition. Otherwise, if the patient can do it, can open the mouth, we don't take so many time to do this, 1 hour and 30 minutes to do an All-On-4, so 3 hours a bimaxillary, it's not so much. Then the prosthetic part where we have to do impressions and capture the cylinders, it's more 30 minutes, 45 minutes. And then at the end of the day, we deliver the fixed bridge. Thank you. If you have more.
Thank you so much. That was, I really liked that presentation. I don't know about you out there, but you know, just showing how it can be done. I mean, everybody sees, and sometimes it's not something, you know, my own take here that, you know, if it's not something you want to consider a multi-disciplinary approach where you have someone who's doing the surgical part and you are doing the prosthetic part, you know, so that is an option and that most people take, you know, so that you have an anesthetist. Sometimes you need an anesthetist there, you know, to be able to, you know, do all that. You say you needed to put the person under general anesthesia. So it's a win-win. At the end of the day, we have all the resources available. You know what your limits are, and this is wonderful information. Dr. Caramelo, I need you to talk to some people in the MALO clinic. I see them on LinkedIn. I need them in the dental webinar series.
Okay.
You guys have a wonderful organization out there, and I see you guys are very good at what you do, and I would like for you to come share your experience.
Someone from another area, just tell me, and I will tell them. They will be very grateful to presenting here for sure.
I listened to you. I mean, I wasn't planning to say this, but just seeing that your organization will go out of its way to take care of people who cannot afford to pay, that touches my heart. That is what I'm about. I'm a dentist that travels around the world and helping people. That's what I've done. And in doing this for dentistry, I'm like, what can I do in this COVID-19 period? So we're doing dental webinars for Africa, you know, because I think this is information that we need. I don't know how many schools have this detail, this type of lectures. I don't know how many schools in the African continent has it. The kind of things that we are receiving right now. And I'm saying, if I have connection, if I have friends in Portugal who can teach, why not? So you can see out here, we have dental webinars going on. We are building in Kaduna. We are rebuilding homes for people. We are picking up health projects. This girl had a burn. She burnt her hands, and the parents have no money to pay. And I'm saying, you know what, I can do something about it. And we're also feeding people, because this COVID-19 period, it's a difficult time. Everywhere in the world, people are going through stress. And Healing Hands, we are saying we can make a difference in the lives of people. Thank you so much, Dr. Caramelo, for joining us today. This has been an amazing time. All right. On Friday, we're going to have Dr. Alberto. Dr. Alberto is a prosthodontist in the Portland area. He'll be here with us to talk about occlusion. You are going to learn a lot. So if you want to tune in with us, you know, sign in and tell your friends. October is filled with a lot of you. We have Dr. Alvin Wee. Dr. Alvin Wee is in charge of the prosthodontic program in University of Minnesota. He's going to be here in the month of August. We have Dr. George Borgia de Feritas from Brazil. He'll be with us. We have Dr. Afsa Afendi. She is in the University of Michigan. We have Dr. Fernanda. Fernanda is with University of Kentucky. We're going to have Dr. Najla Casabre. She's in the University of Michigan. We're going to have Dr. Shubik. Is an oral surgeon in the we just finished his program at the University of Illinois in Chicago. August is loaded. You don't want to miss it. And Dr. Shri will be back on August 15th. He has a very powerful session to give. And we also have another person from Brazil, an oral maxillofacial surgeon, Dr. Leonardo Faverani. He'll be with us. So this is, tell your friends. I need you guys to go to the YouTube channel and subscribe. Tell your friends, go back, listen to these videos, go to Instagram, share it at Healing Hands That Help Society. Let's make this a movement. Let's educate Africa, and let's make dental care, affordable and practice in a safe and very convenient manner. Thank you so much for joining us today. I'll see you next time.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator